Good morning to one and all. Today I am going to discuss about a clinical case, that is when chronic diarrhea meets cholestatic jaundice, a clinical reasoning case. Myself Muhammad Iftakar HJ. I am a third year medico at HIMS Hassan. So today's case is an interesting example like how gastrointestinal disease can involve hepatobiliary system. So here is a patient, 37-year-old woman with chronic diarrhea develops jaundice. So now we should think that what diagnosis connects the intestine and the liver. So as already mentioned, here is a 37-year-old woman presented with chronic diarrhea and later developed jaundice. So let's work through this case step by step. So here is a case history. 37-year-old female having chronic watery diarrhea since 3 months, occasional blood in stool, intermittent abdominal pain, fatigue and mild weight loss is there, and a recent onset jaundice is also there. And when we see into the past history of the patient, she is a known case of type 2 diabetes mellitus, and also there is no alcohol abuse, no IV drug abuse, no recent travel, no family history of inflammatory bowel disease or colon cancer. So this patient is having chronic watery diarrhea for around 3 months, and it is associated with intermittent abdominal pain, occasional blood in stool, and fatigue is there, and mild weight loss is also there. So at this stage, I can say some of the important differentials. It may include inflammatory bowel disease, intestinal infection, it can be intestinal malignancy also, it can be intestinal tuberculosis also. And here it is very important to note that the recent onset jaundice is especially important because it suggests that another system may be involved. And looking into the past history, she is a known case of type 2 diabetes mellitus, and there is no alcohol abuse, IV drug use, or recent travel history also. So on physical examination, vitals are stable, scleral icterus is there, mild right upper quadrant tenderness, palpable non-tender liver edge, no ascites, perianal skin tax, that is very important to note, no oral ulcers or no skin rash. So as I mentioned, on examination there is scleral icterus, which is suggesting that there is clinically significant jaundice, and there was mild right upper quadrant tenderness and mild hepatomegaly is also there. And a very important clue towards our case is the presence of perianal skin tax, and we already know that perianal disease is strongly associated with Crohn's disease, and it immediately increases the suspicion for IBD involving the terminal ileum. So now we'll look into the investigations. So investigations, HbA1c 8.2%, which is suggestive of uncontrolled or poorly controlled type 2 diabetes mellitus. Liver function tests are showing elevated direct bilirubin, elevated ALP, AST, that is ratio of AST by ALT is relatively normal. So which is a suggestive of cholestatic liver function test, cholestatic pattern is there. Ultrasound abdomen is showing mild intrahepatic duct dilation. There are no gallstones. CT abdomen or pelvis, it is showing thickened terminal ileum. Mild hepatic duct dilation is there. No mass lesion is also there, ruling out the possibility of the intestinal carcinoma. And it is also ruling out the gallstone induced gallbladder obstruction. Next, stool OR parasite, it is negative, ruling out some infectious cause for that chronic watery diarrhea. HBV or HCV serology is also negative, ruling out the possibility of viral hepatitis. And it is very important to note that colonoscopy. So colonoscopy is showing patchy erythematous lesions and rectal sparing, and all we know that is patchy erythematous lesions, that is patchy inflammatory areas with rectal sparing, is a classical for Crohn's disease. It is classical for Crohn's disease. And by seeing into the LFTs, there is increased direct bilirubin, increased ALP, and relatively normal AST and ALT. So which is indication of, or it is indicating cholestatic pattern rather than hepatocellular injury. Right. And see, this is the image showing MRCP, which is a non-invasive test, like non-invasive investigation. It is magnetic resonance cholangiopancreatography, which is showing strictures in both intrahepatic as well as extrahepatic ducts of the gallbladder. So it's showing multiple strictures, which is confirming the cholangitis. So now, what is the most likely diagnosis? So at this stage, several important clues are pointing towards a unifying diagnosis, that is terminal ileum involvement, perianal disease is there, patchy colonic lesions, cholestatic LFT pattern, and rectal sparing is also there. So before understanding the most likely diagnosis, we will understand what are the differentials for this case history. So ulcerative colitis is less likely because here rectal sparing is present, but in ulcerative colitis it is the continuous involvement. It is also called as backwash ileitis. So patchy lesions are present. That is a classical for Crohn's disease. In ulcerative lesions, it is the continuous involvement. Terminal ileum involvement. So as we know that Crohn's disease can involve any part of the gastrointestinal tract starting from mouth to anus, and classically it mainly involves the terminal ileum. Perianal skin tags are present, which is suggestive of Crohn's disease, ruling out the possibility of ulcerative colitis. Then colon cancer is also less likely because there is no focal colonic mass. There are and chronic inflammatory features predominate here, and it's an younger age group. 37 is basically an younger age group, and carcinoma are more likely to occur in elderly people. And intestinal tuberculosis is also considered because of the involvement of terminal ileum, but there are no classical features of TB, like there are no fever or night sweats, no TB history is also there, and colonoscopy pattern is favoring Crohn's disease. And choledocholithiasis, so common bile duct obstruction is also considered because of cholestatic pattern of the LFTs, but it is less likely here because there are no gallstones on imaging, and chronic diarrheal illness is suggestive of systemic disease. And viral hepatitis is also less likely because HBV or HCV serology is negative here, cholestatic pattern is predominating, and AST by ALT are not markedly elevated. Right? Yes. So by seeing all this, my final impression is Crohn's disease with associated primary sclerosing cholangitis, and key supporting findings are terminal ileal involvement, patchy colonic lesions, rectal sparing, perianal disease, and cholestatic jaundice pattern. So this is the final diagnosis of this case, and it's very important to note that in any patient with IBD, that is inflammatory bowel disease, development of cholestatic jaundice should raise suspicion for hepatobiliary complications such as primary sclerosing cholangitis. And it is very important to note that primary sclerosing cholangitis is more of association with ulcerative colitis rather than Crohn's disease, but rarely it can be associated with Crohn's disease, as we observed in this case. So thank you.